going to have 3 speakers, and then all of them are going to come and sit up at the front. So if you have any questions, please hold that until all 3 speakers have spoken. Right. So our first speaker on the subject is a postdoctoral fellow in mental health policy at the Department of Healthcare Policy at Harvard Medical School, who has also been at the forefront of concussion research. We are absolutely thrilled to introduce our expert on social norms as they apply to sports-related concussion, Christina Baugh.
Can we just all take a moment to give another round of applause to Emma and Kaylin for pulling everything together today. It's amazing to me when students come together about issues that they care about, and they really have led the charge on bringing us all together today. So thank you both for that. As I said, my name is Christine. I'm currently a postdoc at Harvard Medical School studying mental health policy as it relates to sports injury and concussion. And I'm here today to talk to you a little bit about social norms and concussion reporting. So that's where we're headed for today. I think it's important to acknowledge your backgrounds and perspectives anytime you come into a room, sort of what you bring to the table, what you bring as your experiences. As scientists, we always aim to be objective. But we all come to the table with experiences that shape the way that we view the world. So I am the daughter of a former NFL player. I'm a neuroscience nerd. I've worked at BU where we studied chronic traumatic encephalopathy, diagnosing the brains of individuals after they passed away from death. I'm a former student athlete, so I loved having the student athlete panel up here. I was a rower at Harvard where we occasionally got beat by Brown, but we won't talk about that. And so I think those perspectives inform my opinions, and I think, again, it's really useful to think about the types of things that you bring to the table shaping your viewpoint on the world. So a bit of a roadmap. I'm going to start today. I didn't realize Dr. Small was going to talk about concussion as an entity, so I'm going to just very briefly discuss concussion in the context of college sports. Then I'm going to transition a little bit into concussion education and its current state. We'll talk about what is a social norm and why are we talking about it in relation to concussion education and concussion reporting. And then what do we know about the social norms and reporting around concussions, specifically in college sports. From there, relating what we know back to how we might integrate that into education in the college context in particular. And then finally, bringing up, importantly, some limitations around thinking about concussion reporting as a primary feature of how we try to reduce or eliminate concussions in college or other level of sports. So I won't spend too much time here because we've been here already, but concussion is a brain injury. It's an induced brain injury from an acceleration, deceleration, not necessarily trauma, of the head. Whether your body is hit, whether your head is hit, it doesn't matter where the acceleration or deceleration comes from. We think about this as a transient injury because typically it resolves, again, somewhere in the 1, 2, maybe 3 week time period. Although the athletes were thinking about it necessarily as the brain bouncing around in the skull, this is actually more of a deformation. The brain is the consistency of jello, so if you think about it, it's not necessarily where the impact itself occurs, but the whole shape of the brain can distort during this acceleration, deceleration event. It's a clinical injury. It's an injury that is, again, only known to be diagnosed clinically, meaning that it's an impact that's followed by symptoms. Right, and that's the kind of crux of the issue that we're going to be talking about right now is that there is no biomarker, brain scan, blood test. Currently, for diagnosing concussion, it's very much a clinical diagnosis, a clinical syndrome. We think about it as metabolic. The brain cells, at a cellular level, the brain cells, the neurons are not functioning as they normally would. There's a massive efflux of calcium, influx of potassium. This balance of neurometabolites that normally exists is out of whack, and so the brain is working very hard to regain neurometabolic homeostasis. And it's invisible. It's invisible for the reasons of the lack of brain scan to show something on an image. It's invisible because frequently, externally, another person might not be able to tell when an athlete, a domestic violence victim, an old person with a slip and fall has had a concussion or a brain injury because the symptoms are so internal. So why does reporting matter? This is just a pretty brain picture. I hope my neurologist friends don't like poke at it too much. This is just a slide where I can...
It's not orange.
I know, true. Enhanced for color. Why does reporting matter? So reporting matters in part because we have evidence to suggest that if you have multiple brain injuries in a row, there can be, at least in younger adults or children, very severe neurological consequences. So something called second impact syndrome can occur very rarely, but it is, again, very severe, where if you have one brain injury followed very shortly with another one, the brain can kind of go into a state where it's working overtime and there's a swelling within the skull, and you can have very, very severe neurological consequences all the way up to the level of death from this. So there's like one end of this that's very, very severe. But in the less severe side, we've now started to understand that timely reporting of concussions, timely care delivery for that initial injury is actually associated with a faster recovery time. So not continuing to play during that very acute period following the injury is a critical inflection point, it seems, to enhancing the recovery experience. It also matters because this is the only way, in some cases, that the injury will be diagnosed. It's an invisible injury unless there is an honest report of symptoms in many cases. There might be a more severe injury where somebody's knocked out, has a fencing response, is obviously dizzy or off balance. That's only like a small percentage of the cases. Other times, unless the individual themselves with the concussion comes forth and reports their symptoms, the injury may never be diagnosed medically. Reporting also matters when we think about how we want to structure our education. So one of the main motivations of this workshop today is to think about how to improve the concussion education that's delivered here at Brown, but perhaps elsewhere as well. So underreporting of concussions is a major issue across all levels of sports, but especially in the college level as we understand it. And recognizing and understanding the underreporting issue may help inform how we go about creating an effective concussion education plan. So why are we talking about this particularly in the context of college sports? One, we're at a college. Two, we want to improve college concussion education. But there's a lot of student athletes at the NCAA level, nearly 500,000, nearly 500,000 annually participate in athletics, a number of which are, you already saw the table, in these contact or contact and collision sports. And even those who aren't are still at risk for a variety of injuries, including these incidental concussions that can occur. We have estimates from the NCAA Injury Surveillance Program, which notably does not include water polo, that there are about 4 to 5 diagnosed concussions in this population per 10,000 athletic exposures. That's every game or practice considers one athletic exposure. This is across all sports. So you would see wrestling, football, soccer, ice hockey would be higher, maybe swimming, and other lower contact or non-contact sports would be lower. And again, some estimates suggest that over 50%, I want to know the citation you had for the 10 times number, the CDC one that you referenced, but over 50% underdiagnosed. So that those estimates of the 1.6 to 3.8 million annually may be a gross underestimate based on the underreporting and the mechanism of understanding those injuries. It's also important because we have a national organizing body in the college context. We have the NCAA, which has already made a number of rule changes, including the 2010 rule that mandates the existence of concussion education, but maybe doesn't provide a lot of specificity around that. So because there is a rulemaking body, it's a unique place to think about how you can utilize that policymaking body, whether it's the NCAA, a league, a division, a school. They're all very organized at the college level, so you're able to leverage these policy mechanisms to perhaps make a change you might not be able to in another context where there are fewer resources or less organization.
These guys are very slow to make changes. They will not let us put head
Interesting. When you say they, these guys, gals, people.
NCAA rules committee.
Yeah. So it is the NCAA. I should say it's not like a one. It's not a single body. There are many committees, and in order to make a change that affects all across all schools, the schools themselves actually have to vote on it, and there has to be a majority. So it's not an easy thing to move. You're right. We're moving very incrementally, very slowly, but even at the college level, with those more minor, smaller groups, the schools, the leagues, the divisions, they're able to move independently as long as they're moving under the broader guidance of the NCAA rules and guidelines. They're able to do things that go above and beyond. So we've already seen that in some cases that I'll talk about. So I'm here to talk about norms and concussion reporting. So I think it's kind of important to say what is a norm. So a norm in the context of concussion is kind of the same as it is in any other context, right? So we're thinking about this meta idea of what you think other people will think about your behavior. So a subjective norm is what I think the people I care about, the people who matter to me, will think about what I do. In the context of college sports, we already heard it come up, right? What would your teammates say if you had a concussion? We don't really need the, I don't know the titles, 2 meter, what did you call him? 2 meter defender, right? Similar for all other sports, right? So we're thinking about what others around us, coaches, parents, teammates, classmates. In the context of maybe professional sports, we're thinking about an audience. In the context of high school sports, maybe we're not thinking about such big things, right? But what do the people around you think? What do you think the people around you will think about your behavior? And this has actually been across a range of health behaviors shown to be quite influential in how individuals end up making decisions about what to do. There are a lot of factors that go into this idea of concussion reporting. We're going to be focusing today on this interpersonal issue. What do I think other people will think about my behavior? But there's a lot of individual level stuff. Education, in some ways, is created to convey knowledge. Knowledge would be an individual level trait. Then there's these interpersonal features. We come to institutional features. What does the school do in this context? What kinds of resources does the school have? A broader social context, and then at the biggest level, the policy context, sort of under that largest umbrella. So again, today we're thinking about this interpersonal issue. This framework is called the social ecological model. Again, a public health framework that helps us think about how all of these levels of influence can work together or work against each other when we're thinking about making a change in a particular domain. The theory that has been applied specifically in the area of concussion to think about how social norms or subjective norms have been influential or not influential in concussion reporting behavior amongst athletes is called the theory of planned behavior. So there have been a number of research studies that have been published to try to understand whether this framework, a broader, again, public health, health behavior framework, fits in this context. We've now come to feel pretty confident that there is a good fit for our understanding of how an athlete goes about making a decision to report or not report an injury or a concussion in this realm. And so in the frame of the theory of planned behavior, this subjective norm is a pretty central feature. We've got attitudes, we've got perceived behavioral control. Attitudes we're all pretty familiar with. Perceived behavioral control is like how much confidence I have in my ability to actually execute this behavior. And then these norms. What are other people going to think about what it is that I do? And that all feeds into an individual's intention. Right now, if I were going to predict whether or not I'm going to report or not report my symptoms, these three features, we think, inform that intention. And that intention then informs the behavior. And so this is sort of the big theoretical frame that has underpinned much of the research that's happened so far around this area of concussion reporting and social norms. So what do we know? A lot. Fortunately, I'm going to talk about just a handful of studies that have come up that are part of the broader literature. We have a causal inference specialist in the room, so I'm just going to say outright, these are all association studies. They are building a knowledge base, but they are all very much association studies. So we know a growing amount about this. I'm going to actually move to this next slide. So we know that there are a lot of people in athletes' lives who influence them, whether purposely or not purposely, and their concussion reporting behaviors. The first of these is teammates. So this is just one study. This was a study that was done in ice hockey players, male ice hockey players. This was, I think, 2014. And we asked questions about basically the athletes' perceived subjective norms, so what they thought other people would think about them, if they reported or did not report a concussion. And in this study, we found a very strong association between the athletes' perceived subjective norm of what their teammates would think and whether or not they intended to then report a concussion. So this goes right along the lines of what was already set up here. This is maybe not rocket science, but it's an important feature to think about when we're trying to craft concussion education, when we're trying to craft sort of safe social spaces, when we're trying to think about how to promote healthy behaviors and activities in the context of sports, is teammates have a really influential role, positively or negatively, in fostering concussion reporting activities. Perhaps again, unsurprisingly, coaches also play a really important role. I just heard a story that terrified me a little bit. Katherine Snedaker just told me a story. She was at a meeting recently, where they brought in an expert to provide some concussion education. The coach wanted to be in the room, which could be great, right? The coach was in the room, the education was delivered. The coach walks to the front of the room after the presentation and says, "That was great, but none of my football players will have concussions." Which, like, we hope that they don't, right? But that message is not necessarily to indicate a culture of safety. Like, we're so safe here, like, we have taken all precautions and thus they'll have no concussions. This probably is more indicative of like none of my football players are going to report their concussions. And unfortunately, that type of mentality is pervasive, hopefully less and less, and hopefully not at colleges where we are also trying to foster an education and those sorts of things. But coaches can have very significant effects on their athletes. This is unsurprising. This study was a study of 10 college football teams, survey-based, asked the athletes questions about, again, stakeholders in their lives and whether or not their beliefs about what these stakeholders thought influenced their concussion reporting behaviors. Two interesting features of this study is that there was a very different views about what the coach thought from freshmen compared to everybody else. So the freshmen, newly there, it's the beginning of the first football season they've ever attended at this college, and they thought that the coach was going to be much more supportive than the rest of the team who's been there for a little bit longer. That's a little bit not great. And then secondly, both the freshmen who had these more positive views were also more likely to be reporting their concussions. So is this because of the positive views? Who knows? But there was an association because of this, the support of a coach and the later reporting of concussions.
Is this Division 1A or 1?
This is Division 1, the FCS, not FBS, so not the bowl schools. Although forthcoming work like this replicates up and perhaps with even more magnitude. Interestingly, at the college level, at least I think, is that parents actually still play a very influential role. So this study was in a range of college athletes, so I think it was 10 different sports, both men's and women's, Division 2 or 3, I can't recall, and several hundred athletes. We asked similar questions, again, a variety of stakeholders in your life. And for this study, what we found was having the influence of parents, thinking the perceived subjective norm related to parents, in addition to the other stakeholders we've already talked about, coaches and teammates, was actually quite influential. And I think we sometimes forget, maybe I sometimes forget, maybe you don't, you're still in college, but college students are at this very unique point in life where they're starting to craft an individual adult identity, but they're still very much kind of tied to their parents, sometimes financially, sometimes emotionally, sometimes, you know, in other ways. And so I think this was an important sort of wake-up call that you can still leverage parents as a positive, influential force around this particular kinds of behavior. Again, these are just a handful of studies and a broader range of studies that illustrate these points. So those 3 studies were studies that Emily Crocius and myself, along with a handful of other people, conducted. But there's work by Jana Register-Mahalik and Zach Kerr at UNC that also supports this idea. There's work by Tamara Valovich-McLeod at Arizona State. There's work from a range of scientists across a range of institutions that support this idea that the people in our lives, the people in athletes' lives, are very influential when it comes to their decisions about reporting or not reporting. Forthcoming work that is a little bit different, but important to recognize, especially in the vein of thinking about if we're going to try to craft influential concussion education. So some work coming down the pipeline is demonstrating 2 things. So primarily the work that's been out there so far thinks about concussion reporting as a relatively stagnant feature of a person. Maybe your environment changes, but we kind of only got these single time slices of people's reporting behavior. So the question of this study was, does concussion or injury reporting change with exposure to concussions or injuries, right? So as you've had 1 or 2 or 3 or 4, do you learn and change your likelihood or probability of reporting a concussion or a different injury over time? So is it this stagnant feature, or is it this variable feature of an individual? And what we see is that it's variable. And it's differentially variable between a concussion and a different kind of injury. So we see a decrease in both cases. Non-concussion injuries, individuals are decreasingly likely to report them as they experience more and more, whether this is a learned thing based on trying to differentiate what's serious and not serious, whether it's wanting to continue to participate at all costs as you move along in your career. We're not sure, but it's interesting. Perhaps even more interesting, though, is this environmental feature that we think is happening with that crazy dip around 4. So for concussions, 3 or 4 tends to be this little clinical landmark that sports physicians use when they start to think about, they've had 3 or 4 concussions. Maybe the athlete shouldn't continue to participate in his or her activity. So the probability of reporting dips pretty low, around 4, and we wonder if this is a gaming kind of thing, an unintentional consequence of the policies that we've put in place that, you know, cause physicians who are clearing these athletes to really have a pause about whether or not they want to return them. So this is another kind of social norm, perceived subjective norm of the clinician. What is the clinician going to do or think if I come forth with this injury? So circling back to the whole idea of this presentation, which is how do we tie this back to education, right? We just went through a bunch of studies. Now, let's try to see how this might fit back into the goal of informing concussion education. Fortunately, there's a little bit of work on this. And, you know, perhaps again, unsurprisingly, the athletes know exactly what they want, and it turns out what they want is all pretty great stuff and in line with the evidence, even though they may not even know this evidence exists. So in a study that we conducted with college athletes across the board, we found that they wanted more stakeholders involved in the education process. I'm guessing that they didn't want the coach to come to the front of the room when the education is done and say, you know, but none of my athletes are going to have concussions. What they want is they want buy-in. They want not just the athletic trainer, but also the head coach or the assistant coaches, the position coaches, to be involved in creating this culture around safety. I'm just going to go like this. What we also see, based on the study that I just pulled up, is that this is an opportunity to leverage a misperception. So typically, we have an idea of what other people are going to think. That doesn't always align with reality. So in these subjective norms, what I think other people are going to think if I behave a certain way might not actually be the case. And what we find when we actually measure an objective norm, what the people themselves think, versus a subjective norm, what I think they think, is there is this difference. And at least in the small populations that we measured for that particular study, what we found was coaches and other stakeholders in the environment were much more supportive of safety behaviors than the athletes thought they were. So if we can use education as a way to bridge the gap between what athletes think somebody else wants and what might be more in line with the case, this could be a way to kind of help increase concussion reporting. We've also found that even though knowledge-based concussion education has significant limitations, there are some important features of having enough knowledge about concussion, such as if you have significant understanding of the academic and athletic consequences of a concussion, this has been associated with being more willing to step up for your teammates. Maybe not yourself, but if you're worried about a friend or a teammate, this sort of bystander type intervention seems to be associated with an increased knowledge of the concussion and their consequences. I want to take just a moment to talk about the limitations of reporting. We've talked a lot about underreporting, concussion reporting, right? Very important feature. But there are limitations to this as a mechanism for preventing or reducing the consequences of concussion. First, the path to behavior change is a treacherous one. I think any public health person would tell you this, just out the wazoo, right? Changing the way people act is really hard. That doesn't mean you shouldn't try, and it doesn't mean you shouldn't base it in evidence, right? But it should be one piece of a broader puzzle. Secondarily, the behavior change in this case occurs after a concussion has happened, right? So this is a secondary or tertiary prevention mechanism rather than a primary prevention mechanism. We're not reducing the number of concussions. We're trying to make sure that those who have concussions have the appropriate, timely medical care. There are also really different resources available to athletes across campuses. So this is not the best designed slide, but this is just to illustrate the number of athletes an average athletic trainer at an NCAA school cares for. So at the schools where they care for the fewest number of athletes, right, they really get to know their athletes. They have a much smaller caseload. They care for 29. At the median school, they care for 106 athletes. And at the maximum school, they're caring for 575 athletes. Even if we increase concussion, like we increase the athletes' willingness to report a concussion, they're one of 575 athletes reporting to the same clinician. You've got to track that person down. You have to have some sort of interpersonal knowledge of what this person is going to think if you do this. Are we actually going to get any care if I do report my concussion? Does it matter if I report it if I'm one of 575 athletes that this person's caring for? Catherine?
Do the colors coordinate to any Division I, Division II?
Oh, no, sorry, that's, good, medium. I didn't want to put red on my slide.
So just sizes, those are sizes of just number of athletes and
that's minimum, median, maximum athletes per clinician.
There's something I've only been in this business for a few years. There's something I learned that surprised the heck out of me is that athletic departments, almost all of them, lose an enormous amount of money. And so, that's relevant to this slide. There are few programs that make money because of their football programs, Michigan's and a few like that. But almost every athletic department that I know of that I've talked to, they lose a lot of money. So I understand this kind of exigency here.
Yeah, I guess I would just, I know that to be the case.
Could you just repeat what he said so it's on?
Got it. So it's on the slide. So
If I'm wrong, tell me.
No, you're correct. The point that was made is that the vast majority of college athletic departments are not revenue generating. They quote unquote lose money. I guess I don't want to dig into this too much. The fact you say is true. However, there are a lot of places in which college athletic departments choose to spend their money. And some of those are health promoting and some of those are not health promoting. And the average athletic trainer's salary is unfortunately not that high. Fortunately for a case for making a health promotion decision, it's not that high, right? So adding one additional athletic trainer, the marginal cost of that to an athletics department budget is not significant. And again, forthcoming work, we see that schools who have better staffing patterns within their athletic medicine facilities actually have reduced rates of concussion. This is across sports, across divisions. Like about, what does it say, 6.7% fewer concussions for a school that's one standard deviation better than average in its staffing pattern, so having better number of clinicians. I'm running out of time. Other types of things that we might want to think about in addition would be sort of these bigger level factors, right? Rule changes. This is an Ivy League rule change. Football eliminated contact practices. Turns out if you study that, it shows that there's fewer concussions. Surprise, surprise, but like really important. And this has come up already, but concussion reporting relies on concussions which have symptoms. Perhaps the injury of interest is symptomatic concussion, but perhaps this idea of repetitive brain trauma, regardless of whether or not there are symptoms, is something that we need to be thinking about reducing sort of in and of itself. Again, perhaps through policies around practices or other things to reduce the overall cumulative head impact burden. This one just came out last week or so. Changes in brain scans in high school football players, regardless of concussion status, seen just after one season of contact. So circling back, we have these many levels. Any public health intervention should seriously consider multiple levels of influence. Reporting is an important one. These interpersonal things are really important. Behavior change is hard, but thinking in a multifactorial way about how we can address this stuff will be the most effective. Lots of people contributed to the research I just described. These are a handful of them. Importantly, the athletes themselves and the athletic trainers who fostered the participation of their athletes are the real rock stars of all of this. So I always say thank you. Super duper important.
Next, we have Katherine Snedaker. She's the executive director and the founder of Pink Concussions, an international nonprofit focused on female brain injury from sport, domestic violence and assault, accidents, and military service. We are very happy to have her here with us today to present on sex and gender considerations when it comes to traumatic brain injury.
I really want to thank the organizers of the event. To put something on like this is so much work, especially with finals and everything you guys. So thank you for having us here.
So I want to first talk about cigarettes. If you're studying concussion, you should really watch at least the movie, the series, The Cigarette Wars, because everything that's going on right now with concussion and how it's being represented in the press and who's paying who and doing what really comes from the same playbook as cigarettes. And you'll view the concussion world a lot differently once you do look at cigarettes. So these are ads, actual real ads for cigarette. Gee, Dad, you always get the best of everything, even Marlboro. Before you scold me, Mom, you better light up Marlboro. Gee, Mom, I'm sure you're enjoying your Marlboro. So this was a point where smoking was just about you deserve it. It's part of, the joy. This is the way cigarettes were represented. And then came a time where cigarettes, where the education was starting to come, the research was starting to come out about problems with cigarettes causing illnesses. So then the advertising was switched to every doctor in private practice was asked, and more doctors smoke Camel than any other cigarettes. So this is an example where we went from, hey, it's good, you should do it, to, hey, your doctors are saying it's really good for you. And then the finale in, well, so what happens when the research comes out and the product that you have is actually really bad for people? So here's the winner. Taste isn't the only reason I smoke. People are always telling me that smoking causes low birth weight babies. Talk about a win-win-win. An easy labor, a slim baby, and the full taste of Winston. Winston when you're smoking for two. This is a real ad. So this is showing where, well, we know things are bad, but below birth weight, slim baby. So this is a part of the playbook that was from tobacco, when tobacco took it from the railroad, and the railroad took it from, it's been passed along by industry when you're trying to protect the money that you make. And sports is a business. Amateur sports is a business. Youth sports is a business. College sports is a business. Someone on my Facebook page last year posted that their kids just went to their first international soccer tournament as players, and they're like 7th graders, and they were playing in Spain. Like, do 7th graders really need to play in Spain? I mean, it's great for a trip, but there's money around youth sports. So anyway, let's not forget it's money. So that's my little diversion into cigarettes. So there's me and my kids. This is where I come from. I'm a social worker. I coach youth sports. Coached boys lacrosse, which was very fun. I was one of the few female coaches. And then my son there on the left got a concussion. He was at recess. He got hit by a soccer ball, and I got called by the school nurse was out. I got called by the receptionist who said, "Come pick up your son. He got hit in the head with a soccer ball." I'm like, he's a twin. He gets hit in the head with shovels by his brothers. What does a soccer ball do to my kid? So he was out for 3.5 months, and this was 2008. And we had some medical issues when they were born as preemies, and I was pretty good. I knew people up at Yale. I knew a lot of different people. But when you started talking about concussions, the researchers that were really great when they were premature babies and they had issues with breathing, and actually the one there had a brain bleed, when you got to concussion, everyone was kind of vague. It was 2008, Chris Nowinski's book, Head Games, just had come out, and I read Chris's book, and I literally followed him around for a year like a puppy going, I want to work for you. What you're talking about is great. My son was out for 3.5 months, and he came back to school, 6th grade, totally school phobic. We had to peel him off the floor and get him into the school. We had kept him in a dark room. We had pretty much did everything wrong. Everything they do now, we didn't do. We also had an eye convergence issue, but at the time they weren't looking at eye convergence issues. So here's a kid who missed half of 6th grade for an eye convergence issues as opposed to going to getting himself assessed. But it was 2008. All the heads up information about the CDC was printed about that time. So it really was kind of a cusp. It was also a time that we reevaluated concussion and that loss of consciousness, grading 1, 2, 3, 4, grading concussions was pulled. And then if loss of consciousness wasn't part of concussion, then 90% of the concussions that don't have loss of consciousness were now put into research, and so it opened up the definition of concussion. So I started Sports Cap at that time and went around. I was doing youth sports education. We were invited in by the NFL and we did not do a business deal with the NFL, but I was there when the NFL was trying to decide if they were going to use heads-up football or not, and they were looking at our program. And we did things like the Headbangers Ball, where I had kids, if they wanted a snack, they had to give me a sign of concussion. We had CDC concussion stuff around. I also did a 10-week group with girls with concussion syndrome. It was actually supposed to be a group of kids with concussion syndrome, and then at the clinic where I was working, 13 of the kids were girls and 2 were boys, and by the time we had called and cleared everybody to be a part of the project, the 2 boys were back at school. I went around doing concussion education, school to school, and then cancer hit. And then when they told me I had cancer, I was like, no, you don't understand. I'm not really interested in cancer. I'm going to get CTE, and I'm probably a total neurology person. I'm not really interested in cancer. And they're like, you don't really have a choice. So I was sort of forced to take 15 months off of concussion education. And that was about the time that I had signed up to be part of the legacy study at BU CTE lab. And it was interesting because I called up there and I talked to one of the researchers and I said, just found out I have cancer. You're going to kick me out of the legacy study. And he's like, No, but I think you're really kind of strange that that's important to you. But it was really important to me. It was important to me as an athlete who had suffered concussions to be a part and to be in a group with other athletes that they were studying. So I went through cancer. I had 15 months on chemo and radiation to think, and I came up with this concept of pink concussions because the group that I found that was calling me 3 to 4 months after the concussions were parents of girls. The boys' parents were calling me from the ER in the first week, but it was the girls I kept seeing over and over again with post-concussive syndrome. And while concussion and mild traumatic brain injury have always been viewed through the male perspective, I actually found when I looked that there was research on females. We know that traumatic brain injury in general occurs about twice as often as males as females. And females experience fewer TBIs overall. If you look at this area right here, the greatest divergence between women, the dotted line, and the men is in this group age 5 to 25. It evens out, and then it kind of goes. So it's different over the time frame. So why do males get more concussions than females? This is my slide to explain why. You can take that. I have 3 brothers and 3 sons. So that's why I think guys get more concussions than females. Moving right along. Female life cycle. So we have an injury in toddlers, shaken baby, falls, injuries when you're starting to ride bikes, starting to be more athletic. You have vulnerabilities where you're dating, driving cars, out on your own for your first situations, living on your own, date rape. There's just a variety of violence that can come into a woman's life at that time frame. Also military service, car accidents in this phase, and then elder falls and older life. But what happens when you have an injury with a young child? As a child, how does that affect the rest of your life? So what I did is I looked at sports data, I looked at accident data, domestic violence data, and military data. And if you take the bodies that were part of all of this research, you really do have quite a nice bunch of literature on female concussion. But what was interesting is those groups didn't really talk to each other. There wasn't an area where people all came together. So the research showed, and this had been from research that was around 1999, 1998, 2002, and 2003, that females have been shown in multiple research studies to sustain more concussions at a higher rate than male counterparts when sports with the same rules, report a higher number and more severe symptoms than male, and have longer recovery periods than male. And how do these facts translate? We're going to skip for a moment why, but how did the facts translate? So if there's more men than women that have concussion, she will know more men than females who have had concussions. So you're going to be judging yourself as a woman by the male's experience. And if you have more symptoms, more severe symptoms, and your recovery is longer than the male you know, it's probably because you're doing something wrong. That's usually how it gets translated. So while the 2012 was also the same things with more sports medicine policy, and if your recovery lasts more than a few weeks, then there's this secondary layer of symptoms of depression, isolation, self-doubt, and anxiety. And anxiety and depression can also be a part of concussion, but this is a second layer of it that hits when you get isolated. And if your family, your employer, your school, your friends questioning you whether you're malingering, then that really puts a damper on your psyche. Now that didn't happen with cancer. As soon as I said I had cancer, I knew my hair was going to fall out. So I did St. Baldrick's, which was kind of a cheat because I knew my hair was falling out 2 weeks later anyway. But shaved my head. My friends gave me like $3,000 to give to pediatric brain injury. Nobody ever said a word to me like, "Are you sure your cancer's real? Are you sure that's just a lump?" Like once I said I had cancer, people were giving me money, they were bringing me food, they were bringing me casseroles. It was a complete, party train of food, presents, and gifts. Now, my son with that concussion, nobody even brought us a meatloaf. He's out of school for 3.5 months. I practically quit my job. Nothing. You do not get casseroles for concussions. I literally had to tell them to stop baking for me for the cancer thing. So my first study was in 2012, 2013, No Guts, No Glory, the price she pays to play the game. And so this was a study I did in 2012 with Clemson, and we used Twitter, and we did snowball method. And within what we knew about concussions were the media report, personal experiences, and we wanted to look at the communication. And we wanted to know, why do athletes continue to play after experience concussive syndromes? And do female athletes hide their concussions as much as males? Because this whole thing that, women are completely honest. Like, I can't wait to someone to say in a relationship, women are completely honest in real estate. You should really have a female. We aren't put on this pedestal except for in this one area. So do we hide the concussions for the same reason? How am I doing on time? Okay, gotta speed up. So female athletes receive twice as many concussions as males in sports with the same rules. So that's where risk isn't taken out. Men don't play soccer with machetes or explosives. The risk levels are the same. And after concussion, women tend to have more severe symptoms and longer recoveries than males. So we did a sampling. We attracted men and females, and we had almost 800 in total. And the average female participant had a concussion at the average age of 19. This data, so it's 2012, their average age was 29 at the time in their first concussion. So this is a group that went through colleges 20 years ago, 15 years ago, 10 to 15 years ago. So this is an older group. They had 4 concussions diagnosed by an AT, 6 concussions, hidden concussions. They averaged 2 concussions. Now, these are people that we said, do you have a concussion playing sport? This wasn't the general population. We already had asked people with concussions to come forward. So I'm going to skip to most of the questions, male and females, were pretty much the same. Did you ever suffer but continue to play through without reporting of a head injury? Now, we always say that women are more honest. Okay, 70 to 79%. Yeah, they're in that situation, maybe they are, quote unquote, more honest, but we still have 70% of the female athletes not reporting concussions. So when I was doing this with my co-writers, they're like, yeah, we're going to put down, they wrote a sentence saying that women are more honest than men and report more, but we still have 70% of our athletes at that point hiding their concussions. Did you ever continue to play after reporting through a head injury? Now, hopefully, this statistic would be 0 and 0. We really hope that you aren't reporting to your coach that you think you have a concussion and they're putting you back in the game. So this is a historical data. Have you suffered any other serious head injuries other than organized sports? Look how much more the women had gone on to have other concussions. And then the memory thing, and the symptoms were pretty much followed each other between men and females. Okay, this is the last one. Why didn't you report your symptoms? So this is the older group, but the lack of awareness, 64%. And if you look for the number one with the man, it was the allegiance to the team. So it was the women who were lacking awareness of what it was, and then they had a lack of resources. Like, I don't know what it is, I don't really have anyone to report it to, and I want to keep playing. And the guys are kind of like, I know what it is, but I still want to keep playing. So there was a difference in the education, that the women knew less about concussions than men, and how we design concussion education. So this is not published data, no tweeting. This is a study that I did this spring, which is really exciting. We did 1,900 kids under 18. If anyone's ever done research out there, it's really hard to get an IRB out of under 18. And we got 1,900 kids at private schools. And it was really interesting. The way that we got this study is my co-investigator is an athletic trainer. So he was head of all the athletic trainers in the area and asked them. So the athletic trainers were the first people that bought into the idea of this study. They went to their athletic directors went to their headmasters. So rather than going top down, we went bottom up. We had 15 schools take part. We have 1,900 kids, and we ran it by the CDC, and they like it, and so we're writing a paper with them right now, which is pretty cool. So just a little bit of the data is, what are some of the reasons for not reporting your concussion? So this is males to females. And in the, I knew I had a concussion I wanted to keep playing was the largest for the males. And then for the females, it was 26. I thought I had concussion, but I wasn't that serious. So it sounds, from this that the women are starting to know what they are, but they still don't have the education. And just if you look at this age group, if you play FIFA or you play Madden, if you play video games, that's incorporated into part of that game. In FIFA, and I don't know, I just texted my son, he didn't answer me. I don't know if it's in the 2018 FIFA, but in the past in FIFA, the video games, players would get concussions, and in some of those versions, you actually had to pay part of your coinage to get your player back to play. So it was part of the game. First-person shooter, you're always going for the head shot. There's definitely this importance of head. There isn't an equivalent in female play. My Pretty Little Pony gets a concussion. Like, I've talked to parents of girls, and I'm like, how do we incorporate concussion into girls' play? Because they don't have as much of it as they're coming to. And in the end, from what I found is, yeah, athletic trainers are there for everybody if your school's lucky even to have one, but they're not at the girls' volleyball game. They're at the boys' football game. So I think in the long run, girls have fewer education and they have less access to care. How am I doing? Okay. How long did it take to return to a full academic workload? So males are on the top, females are on the bottom. And it took, how long did you return to your academic load? 47% of the boys returned within less than 7 days, 36 of the girls. And if you look out here, when it took 21 days or more, 7% of the boys took 21 days or more, 19% of the girls. And this is getting back to school. Okay, this isn't getting back to work. This is just going back to school. That's a lot of girls not getting back to school. And no matter what teachers say, they don't like staying home. They really don't. After 21 days, you want to be back in school. And some of the frustration I have, and which started behind this study, was teachers. It's always a few of them. They happen to sometimes be the highest level at the most prestigious schools that really feel like the kids are taking advantage of the system. I teach AP history. I'm the most important person ever to have taught this, and if this child doesn't do a 10-page paper on the French Revolution, the whole world's going to collapse. And that's the kind of attitude sometimes we get, and I find it less at the college level than I do at the high school level. So here we have girls taking longer times. How long did it take you to return to your sport and play in games? When we said the same patterns again, with the guys getting back less than 7 days and the girls taking 21 days or more. Now, you're not taking 21 days away from a team that you love because you're having fun, not playing with your friends. So differences in that. And then this is the part where I really get upset with schools that think that the kids are pretending to go back. I've heard it from athletic directors, I've heard it from teachers, they're taking advantage of the system. Have you ever pretended to have a slower recovery from a concussion to stay out of sports longer than you needed to be sidelined? Like, are you dragging your feet coming back? We're having 2 to 1% males to females that they are taking a longer time. That means dragging their feet about it. Have you pretended to have a faster recovery? Look at those numbers. These kids from, are you faking and staying out longer than you need to? Are you going back earlier than you think? Okay, and then the same, have you ever pretended to have a concussion to be excused from schoolwork? And a couple, 1 to 2%. Have you ever known anyone in your school to pretend to have a concussion? So their perception was that their friends are faking concussions. But if you look at, are you doing it yourself? So there's the perception, we were talking about norms between what you think other people are doing, and what you're reporting yourself. And the last thing is that we asked if you were going to, think about the experience and that of other students with concussions at your school and rate the staff on how they handle it. And the most approachable, coaches at the school that are understanding, approachable, and fair in how they handle it. So the coaches got the highest marks, the athletic trainer next, the teachers and the administrators. And so I really believe that we need to start working with our administrators, because I feel like if our administrators understand that these kids aren't faking concussions, they're not gaming the system, that some of this stuff can change. And these were at private schools that had concussion education for at least 5 or 6 years, and they had full-time athletic trainers. So the takeaway is to advocate and support females in slightly different. All right, so really just quickly, one of the number one thing I say to women that call me that have post-concussive syndrome is I say you're not bad, crazy, stupid, or malingering. And usually the person on the other end of the phone, female, cries and tells me how important it is what I've just told them. And it's really sad to me that I can be having a meaningful effect on someone's life telling them they're not crazy and they actually have a brain injury. You know, and that they need to re-engage with the medical world. And if they've come across a doctor that said that they had mental health issues, that maybe that was about depression and anxiety that's part of brain injury, and it would be a counselor to help them through their situation. It's not that they're a crazy person. So is it that the doctors are pushing those post-concussive women away because they're spending too long in their practices and they're driving down their patient satisfaction numbers? And if you're a neurologist, is this the group you really want to deal with? Is this where this is not probably the group you went to medical school to help? Or is it that the doctors are just trying to push the mental health aspects of anxiety and depression, and patients are taking their message wrong? But there's this huge divergence of women leaving medical care and ending up, I don't really have time to explain that one. So our mission at Pink Concussions is general education, professional training, and our goals are pre-injury education and post-injury care. And we really hope to connect with Brown and stay together on a part of that journey. We've had 5 international summits. We had the first female CTE event in New York. We hoped that we got 50 people. We had 150 people there. We have over 80 now on our professional advisory board, and we have 3,500 members on our Facebook support groups. So we have support groups for women under 25, women over 25, parents, caregivers, veterans, and a professionals group. We have great leadership, professional advisory board. We have about 80 videos up on our website. We have awesome interns all across the country. We give out awards. And these are some of the events I've had at the Palo Alto VA. This was our first pediatric concussion event. When I sent out abstracts, I didn't know how many pediatric abstracts we were going to get in female concussion. We could have had 3 days work. And if you ever see research coming out from the 5P studies in Canada, it's awesome. So keep an eye out for that, because they are showing male and female differences in concussion down to age 4 years old. This is our meeting at NIH. We have a really great paper from our NIH meeting if anybody wants a copy of that. We do webinars. It's our CTE event with Mount Sinai. I gave the first presentation to the U.S. Army at Launchstool Regional Medical Center. It's the largest medical center outside of the U.S. for the military, and we talked about force readiness and lethality of the force, and how female soldiers and brain injury moved into those topics. Scariest talk ever, entire sea of camouflage, but it went over well. I don't usually talk about the topic with lethality of the force and force readiness, but we pulled it off. And the Army has been incredibly supportive, and the VA has been incredibly supportive of our work. We're on Twitter, we're on Facebook. Just the last one more minute. So this is in the last 6. This was last year at this time, and the numbers are still the same. In about a month, about 2 months, in the last 60 days, we have about 900 posts on our one support group. And from those 900 posts, we had 13,000 comments and 23,000 emojis. And the numbers keep showing, like, people are very active in our groups. And you bring a group of women together, and I always thought those sewing circles from the historical times, like they actually like to sew. I don't think they like to sew at all. I think it was the team, let's get together and basically, discuss, complain, share ideas, share resources. So you put women together. Women in our groups get better because they find other women like them. They share information. And, there's a group that goes off and wants to talk about medical marijuana. It's not a topic I'm into, but that's a topic that they want. There's a group that goes off and talks about the ketone diet. And there's a group that talks about, hey, I'm in the middle of a lawsuit. Whatever interests you is in this huge group, and you can pull together information. Last thing is including female in lab research. In the 50s, when the research at TBI started to tick up, what they found is that the female rats threw off the cycles. The female rat cycles threw off the research, so it was easier just to throw out the female rats. And NIH has been working very hard to fund and bring females back into research as a whole other lecture. But they didn't throw the female rats out because the female rats were reporting more. They didn't throw the female rats out because they were complaining more or they were just irritable. They threw out the female rats because the female rats' hormone cycles made the results turn out to be differently. It's a sex difference, not a gender difference. It's a biological difference, and it's an amazing variable. And the research from the VA that's so fantastic, they were studying soldiers, and the cohorts that fell out as really different were males to females based on sex differences. Another lecture. So we do Pink Brain Pledge. We've had 350 women donate to these, pledge their brains to these organizations. It just signed something with, in the UK to start another thing there. So it's really important. Our next event is in Tampa. We have a book coming out. Thank you.
Our next speaker is an expert in the field of mental health and the director of Rhode Island CBT, a large cognitive behavioral therapy and coaching practice, here to speak to us about the intersections between mental health and sports-related traumatic brain injury. We're excited to welcome Dr. Ben Johnson, joined by Dr. Meg Curran.
Thank you.
Well, thank you for having me. I work with Dr. Johnson at Rhode Island Cognitive Behavioral Therapy. I just joined the practice in September after finishing my postdoc at Brown. And I'm a neuropsychologist, so hopefully I can bring a little bit of that perspective to today's conference. And I think that it flows pretty naturally from Katherine's talk just now, because I find that something I enjoy working with people who have experienced mild brain injuries and concussion, I get to bring maybe a little bit of validation to their experience of symptoms and also provide education support after and while they're recovering. So I thought that it might make sense, I pressed the space bar, you said, to talk about the role of the neuropsychologist. And because I see patients most often while they're recovering and who are complaining of persisting symptoms, I would talk about post-concussive syndrome, the expected recovery, what those persisting symptoms look like, and then how we're starting to understand PCS as a neuropsychological disorder. So, as a neuropsychologist, we are clinical psychologists by training who have additional specialized training in neuroanatomy and brain behavior relationships. And in the clinical setting, we primarily do evaluations of people who have had neurologic and other disorders that affect the brain nervous system. And psychological functioning. And so when we see people who have experienced mild TBIs, we're really just involved in doing an objective assessment of their cognitive functioning. So those memory complaints, the concentration complaints, that fogginess or slowed processing that a lot of people experience when they're recovering from concussion. So we can provide information about their strengths and weaknesses, demonstrate whether or not there are any areas of continued difficulty, and consider all of the factors that might be contributing to some of these ongoing subjective complaints, and identify these different factors that might be amenable to treatment, and come up with a treatment plan. And some neuropsychologists are involved at doing baseline testing. So each of the major national sports teams has a neuropsychologist on staff who will do baseline evaluations, and then athletes are often seen right after their injury, and in a medical or in a hospital setting, neuropsychologists might see someone who's got acute symptoms right after the injury. And very often we come into play after the acute symptoms have resolved, but when these post-concussive syndrome symptoms are persisting. And so we're positioned well to provide education, support about post-concussive syndrome. You've probably already discussed this, but the common acute symptoms of mild head injury are things like dizziness and headache, light sensitivity, blurred vision, neck pain, fatigue, sleep disturbance, and changes in mood or behavior. But these are expected to be temporary. And I wanted to talk a little bit about the natural history of concussion, so what we would expect with recovery. And maybe the first way to talk about that is to think about what actually happens to the brain, to brain tissue, and to your neurochemistry after the injury. And so this is a graphic starting with right at the time of the injury, and then this portion of the scale is the minutes, and then it cuts to hours and then days after recovery. So you see that there's this neurometabolic disruption. So with a mild TBI or concussion, we don't expect to be able to pick up on any damage with CT, but when we look down at the neurometabolic level, we can see that there's just some functional disruptions. And so those acute symptoms are really the result of this. But you can see that these disruptions resolve to baseline within hours to days. So with most people looking metabolically the way they did at baseline 10 days after the acute injury. And the research on symptom recovery tracks really well with what we see with neurophysiology. And so over here are just reported symptoms. And so this is baseline testing, and the white dot is controls versus dark dots somebody with the head injury. So at the time of concussion, there's the spike in symptoms. But then within a week, people who are experiencing concussion look much more like the controls. And similarly, this is cognitive recovery. You see a drop in those scores right after injury with a gradual recovery, again within a week. So there are a portion of people who do take several weeks or a month or two. A lot of that has to do with baseline factors or whether or not, yes?
Do you know if those are males or females?
So this was college athletes, and so it's primarily males. And
And I do know the slide earlier, because Chris Dees is on board, that was male rats.
yeah, for the neurometabolic recovery, yeah. And I think that I'm really excited to hear that that those of you who are looking specifically at those gender differences, because I think that those sex differences are not well represented. And a lot of the data is athletes, young athletes, that we're able to study this more in, and that distinction isn't being made, and the women are very much underrepresented. So that, yeah, major caveat here. Okay, but the take-home message being that a lot of these symptoms, both subjective complaints and cognitive symptoms, track well with the brain's actual functional recovery. We are having a hard time trying to really pin down a good definition for post-concussion syndrome, but ICD-10 criteria includes the following. So you have to have the history of head trauma. Interestingly, both the DSM and ICD-10 say that there should be with loss of consciousness, and so there's a lot of argument in the field about whether that should be a part of the definition or not, because a lot of people who have PCS didn't experience loss of consciousness. And I still diagnose PCS even when there hasn't been. But there's definitely been some kind of blow to the head, and then symptoms in 3 or more of the following categories. And these include sort of the diffuse neurologic complaints, irritability, depression, anxiety, the changes in mood, subjective cognitive complaints, without evidence of neuropsych impairment, because we see that objective testing, those objective deficits go away, but you can still have subjective complaints. And then sleep disturbance, reduced alcohol tolerance. And again, I think the research has a lot of confounds looking at the number of people who actually experience PCS. But when you try to control for a lot of those confounds, including how samples become biased because they're presenting to clinics, and that's how we're obtaining them, approximately 1 to 5% of MTBI patients will experience PCS. And I want to emphasize that this is persisting symptoms beyond 3 to 6 months. So I don't mean beyond a week or two, but 3 to 6 months later, about 1 to 5% of people with a mild TBI will still have persisting symptoms. And based on looking at this, you'll notice that these symptoms are very nonspecific. And actually, they're commonly reported in daily life, and we tend to not be good at judging the difference between the symptoms we're experiencing now after concussion versus what we had in daily life, kind of like a grass was greener before my head injury. And also these symptoms, these nonspecific symptoms, occur in a variety of other psychological and medical conditions separate from head injury. So I think the final take-homes I wanted to present, coming from the neuropsych perspective, is that our understanding of PCS now is that your brain has recovered. So the post-concussive syndrome is not caused by persisting brain damage.
How do you know that? Based on what?
But based on the physiological data that the brain has actually recovered.
When someone comes to you with PCS, how do you know their brain has recovered?
There's been no evidence of a brain injury on scanning, and based on research with samples of the physiological data, even not just metabolically represented in things like PET and SPECT studies, the changes, the disruption in function has resolved at, by 3 to 6 months.
You can talk offline. I take
Yeah.
great issue with that comment. I don't believe it.
Okay. I am certainly not saying that these symptoms are not real, and I think the next point is definitely accurate, that PCS is triggered by a blow to the head, and that once we've gotten to 3 to 6 months, and again, this is with just a mild concussion, and I'm not discussing in this talk the repeat injuries, but these symptoms are maintained by non-head injury related factors that often have been triggered or exacerbated by the original injury. And so there is research looking into some of the baseline factors that contribute to somebody's risk of experiencing PCS, as well as new onset factors that take place at the time of or after the head injury, and those would include beliefs about their injury and expected recovery, any post-traumatic stress that develops related to the injury, as well as anxiety and depression that can be either exacerbated by or triggered by the head injury, poor sleep, and chronic pain and other musculoskeletal injuries that are exacerbating these symptoms, because these symptoms also appear in people who only experience musculoskeletal injuries other than head injury. People without a head injury can also experience these symptoms. And so successful treatment requires a multidisciplinary approach and education, and also trying to identify all of these factors that are likely contributing to persisting symptoms.
I just want to share a couple of my thoughts from a broader coping perspective. This is just the space bar here. I'm the past president of the Rhode Island Psychological Association, the director of cognitive behavioral therapy practice, and I focus on talking to people about anxiety, depression, and coping with all sorts of challenges. So that's my broad perspective. just want to share a few basic concepts about resilience and how to improve it in general, a few tips for recovering from concussions, and just orient you a little bit to what a patient might experience if they were to come into our practice. And I was thinking in particular, just thinking what messages I'd like to put out if I were talking to a Brown team and before injury, is there anything I might want to tell people? So here are just a couple of tips from my perspective to build resilience psychologically in general. So first, I just thought I would start, and if I had more time, I would pull this out of the audience, but I just wanted to start by throwing a profile up there of a student and see if you can just sort of get a feel for this kind of style. So I picture in person one, let's call him Rick, a really highly competitive guy, very outcome focused, determined to win. He's got a rigid personality style, bit of an all or nothing thinking style, that you're either good or you're bad, and doesn't talk about emotions much, maybe a limited emotional range. He always seems either really good or is really bad. He's got a lot of teammates, but few close friends with which he shares his experience with. He doesn't talk that much. Maybe he's got a somatic, what we call somatic focus, a body focus. He tends to experience stress in his body, maybe a lot of muscle tension, backache, something like that. So that's profile one. We'll call that Rick, right? Profile two, it's called profile two, Lisa. Just picture someone who's also incredibly competitive, but she's focused more on progress in her game than winning per se. Let's picture her as emotionally expressive and fluent. Let's say she speaks frequently to her parents, maybe her mother. She's got a diverse group of friends and activities, both on the team and off the team. She's struggled with other things in her life. She's recovered from various injuries. Maybe she blew a knee out at some point and she got over that. She tends to see the gray area in life and the silver lining fairly easily. Maybe she's got a good sense of humor. Tends to downplay her aches and pains, though not avoidant of them. So two profiles. Generally, who's going to recover from a concussion or a car injury or anything else better, Rick or Lisa? Lisa, right. So that's, and I've seen both styles out there, and pardon me. No. Thanks. Is that better? Great, thanks. I've seen both personality styles out there. So these aren't hard and fast rules, but so if I were to be talking to a team, what I would be trying to tell you guys is increase emotional awareness. We know, generally speaking, it's going to help your teammates if you all increase emotional awareness. How do you do that? Step one is identifying emotions. So I like to coach people in a one-sentence diary technique. Before bed, on your phone or in a book, just do a one-sentence diary, best point and worst point of the day. Sometimes if people aren't used to journaling, just a one-sentence maneuver can get them going. That tends to build emotional awareness. Generally, I want to, and my patients, and generally I'd be telling the team, try to increase your emotional vocabulary. We talk in our field about soft emotions versus hard emotions. And what I would be trying to tell the team is build the language of soft emotions. Be able to talk about the subtle feelings, hurt, worry, frustration is incredibly important. Vulnerability, shame, embarrassment. All those soft emotions, I want my patients to be fluent in those things, and I think generally that would help. Be fluent in the language of positive emotions: pride, joy, peace, contentment, safety, calm, aliveness. Emotional language helps, and some people are more fluent and some people are less fluent. Generally, to increase emotional awareness, I want people to share emotional content, have good relationships, and self-disclose reciprocally. So on the team, hopefully there's some habit of sharing how people are really feeling with each other about the good points and the bad points of their lives and days. Generally, I would want the team to be asking open-ended, emotionally alive questions. I'm a psychologist, I'm a therapist, so yes, I want people to talk about their feelings. There's good research saying it tends to help. Talking about our feelings tends to help. Yeah, maybe these are a little shrinky, but what kinds of things would I want you guys asking each other over a cup of coffee? What are you feeling as you think about the upcoming season, right? I actually want you talking about how do you feel about the season. Sometimes just really asking a friend or family member, how are you doing under the hood? Maybe I asked my son that the other day. You know, he tends to be fine, but I asked, well, how are you feeling under the hood? And that prompts a little more emotional talk. What's the term been like for you lately? Open-ended, talking about emotions. There's good evidence it helps build resiliency. What's been on your mind this week? On a team, best moment of the week, worst moment of the week. Just that simple move, I think, really does build resilience. Who is most supportive of you these days? I would like everyone on the team to really be able to answer that question. Who in your life is most supportive? Because if it starts raining, if something bad happens, I want you to know who is most supportive in your life. That makes sense to people so far? How else do we build resiliency? Cultivate supportive relationships and authentic talk. So what do I want the team doing? Yeah, diversify your support network. I don't want the athletes just hanging with the athletes. I want you to diversify that. I want you to also create context for sharing. One of my friends and I, we go out to breakfast on Saturday mornings, and that's a context for sharing. With my wife, we go for walks. Walking tends to help be a good context. So think about the context. Maybe the 5 minutes before class, before a lecture starts, isn't a great context for really sharing. That's a context for superficiality, which is fine too. I want, in general, with your relationships to personalize quickly and look to deepen relationships. Sometimes guys, for instance, have lots of acquaintances, but they don't really go deep with anyone. And so then when something really bad happens, they don't have any practice at doing that. So I'd like to argue that's another way to build resiliency. People with me so far? Okay. I could do a whole hour on communication skills. Yes, I do want the team. Okay, 5 minutes. I do want the team working on their communication skills. I do want you to work at empathizing with each other, validating feelings. Normalizing is the skill we say, just putting one's experience in a normative context. So talking about what it's like to feel stressed and overwhelmed is what a lot of students are going to be discussing. All right. What do I want the teammates doing? Increasing self-care, self-acceptance, self-compassion. I think generally what can get some people in trouble is having demanding perfectionistic standards. So I'm often working with my patients to soften their standards, to bring in self-care and self-nourishing behavior as part of their repertoire. And tune into your full range of needs. Sometimes what happens is people are very aware of their need to win, but they're not aware of their need to relax or sleep or rest or play. Sometimes people are so used to being achievement-oriented that they've really gotten away from a core human need to play, right? And that's really important when it comes from resilience research. Okay, here's the big slide. If you take anything from this talk, what do I want the team doing? Practice flexibility, right? Flexibility, we know, is the foundation of mental health. So a lot of research is all about helping our patients be more flexible. So break rigid routines. If one of your teammates tends to be a very rigid person where it always has to, they're eating the same thing every day, they're doing the same thing, that is a setup for trouble adjusting and coping to life's slings and arrows. So generally, I want you guys working on breaking rigid routines. I encourage an experimental mindset in us all. Experiment with different foods, movies, friends, lectures. Experimentation is the royal road to growth. Be a creative problem solver. Just a couple of last tips, and then I'll turn it over. We want to avoid coping extremes. So in our practice, what we would see, some people are going to under-accommodate and pretend they're just fine. Some people are going to over-accommodate and get into major avoidance patterns. And so we're going to be trying to help someone figure out, are they going to one extreme or the other? Pacing strategies are key. I'll give you one other general tip. Hypervigilance and scanning is something we see in the anxiety disorders all the time. That means when we get worried about something, we start to scan to see how we're doing. Some people with panic attacks maybe start to scan their heart a lot. Is my heartbeat normal? Other people who get nervous about being ill might touch their forehead a lot, and they'll start scanning for, do I have a fever? Other people might scan their intellectual functioning. Is my memory impaired? And that kind of scanning can create problems. I can probably close on this. Part of what we're doing from the psychologist perspective is helping people accept the inherent uncertainties of living. And some people are much better than others at this. Language, I might be encouraging you to say to yourselves and your teammates, let's let this unfold. My power is in my coping, not knowing when this is going to be over, right? What many people are doing, when will I be fine? And really, life is uncertain, and we have to build tolerance for uncertainty. We have to help people realize worrying doesn't help. I'll have to deal the best I can with whatever comes. Some patients are worriers, and that's often going to be a target. And I'm going to try to help people realizing that thinking about the future so much is often going to be creating trouble. So I'm going to try to pull you back to the present. I do help people label compulsive reassurance seeking, ruminations, catastrophizing, thinking nothing but the worst. Just having the labels can be helpful. What do I want you doing? When you're recovering, run small, frequent, fresh experiments and get data about functioning. And surf anxious feelings. A lot of what I'm doing with patients is helping them get better at rolling with things, you're going to have good moments and bad moments, and being gentle with themselves as they ride it out. Okay, I'll close there. I did bring 2 columns, one on psychological resiliency that I wrote, and another on sports psychology.
All right, so if anybody has a question or comment for this group.
Just,
Oh, can you introduce yourself too?
oh, sorry, I'm Mark Beakey. I'm the co-founder of Concussion Coach. I'm based out in Dublin, Ireland. So just kind of have a couple of questions. The first one I suppose I'll put towards Katherine and Christine, if that's okay. You had up on the slides there of having the big tobacco. I understand how they obviously manipulated the media, and then I suppose the same thing could be said for the asbestos. Do you think based on, I'm not sure if you were trying to link that into the NFL, but do you think based on what we don't know on CTE, do you think it kind of pulling the cart before the horse, putting that in with the CTE debate, putting the big tobacco? As in, do you think they're actively, I suppose, withholding information or trying to put the blame down somewhere else where, in the fact, could it be postulated that there's just so much that we don't know that's in relation to CTE? Sorry, that was kind of a long-winded question.
I do think that there is...
I'm sorry, just not to interrupt. I'm not trying to advocate for the NFL or anything like that. Or I'm just saying, just to put that out there. I have no conflicts of interest.
She's got no.
There's many ways to look at the argument, and I think that there are people that are invested in a certain type of sport and in a certain industry, and I think that you can not look at problems. When problems come up, you can discredit the scientists that exist, and then I think you can then move forward to creating your own scientists, and then I think you can you can stretch out the argument, whether that be tobacco, whether that be CTE. I just personally find it interesting that the NFL just decided to fund a high school surveillance program, which is something that has been Dawn Comstock runs Rio and spends a lot of her time, fundraising and trying to get money to continue her work. And the NFL just funded a study in Canada for high school surveillance in a country that doesn't have youth football, doesn't have American football. So, it's where you place your money. I think that it's interesting to look at that history and then look at the history that we're in right now and take away from their own situation. I very much thought personally before I became part of the BUCT study that with my multiple concussions that I was personally probably headed in that direction, and now based on the research that I've read and the last 10 years being in this space, I absolutely do not think I'm a candidate. When women call me and are afraid that they have CTE, I'm like, have you had your mammogram? Like, there's a lot of other things that could take you out besides CTE. And if it's someone that says that they have a history of domestic violence, then I say, you know what? I know some really great researchers, and you should be part of a study that's looking at domestic violence. But for the average woman athlete, I think mammogram. And again, actually it's funny, I just had my neuropsychs done. It's been an 11-year gap since I had them done, and I said, do I have a little bit of cognitive decline? And I got a little nervous right before I did them, and I usually don't think about it. And he goes, yeah, I see some cognitive decline. And I was like, oh. And he's like, yeah, but compared to other 50-year-olds, you're just fine. I'm like, oh, I'm aging. That's what it is. I'm aging. So, I think there's the personal discussion of CTE, and I think there's the larger discussion. I do think that tobacco has some lessons for us.
No, I just thought because you've published quite a considerable amount. If you do that,
yeah, no, I mean, I didn't make
that was a good answer.
the analogy between the big tobacco and that was all Katherine. But I do think that there's something to be learned, not just from her bringing those two things together, but about previous literature like Kathleen's work in drawing parallels in not necessarily where the science is, but the tactics that the two industries have come forth with. And I'm sure Katherine's actually going to talk about this much more in detail, but the manufacture of doubt, the tactics to focus the discussion in certain places, it at least brings up the question. And so I don't want to steal Katherine's thunder. She's going to take the limelight on that one. But yeah, I guess that's all I have to say.
All right, do we have any other questions?
Do you mind if I ask one more?
That's fine.
This has a question.
From Ireland, he gets an extra question.
Sorry, just on Megan, on your point about the PCS being more of a psychological rather than having metabolic, right? I think that might have got lost in the translation. Just kind of defend your point. In the actual term PCS, I think needs to be looked at, because she is right in the ICM classification that it is. It's just not saying that there can't be any long-lasting problems due to concussion, but the term itself is diagnosed from a psychological point. So that's maybe a topic of conversation that needs to happen.
Yeah, I would agree with that. I'm not sure this is on anymore, but
Yeah, press the bottom.
And hold it for 3 seconds.
thank you. Okay. Yeah. It keeps turning red, so it might be dying. But when I am working with patients who have PCS, I spend a lot of my time stating very clearly that I don't believe that they are malingering or that they're making these symptoms up, but that we can no longer, with the technology that we have, point to a physiological reason that these symptoms are persisting, but rather, and we're seeing people benefit from us targeting these other factors that made them vulnerable in addition to the actual injury that triggered the syndrome. And I am interested to see how the conceptualization of PCS and maybe even the label for it will change over time. So, yeah.
What I find is that there's the injury, and then there's the isolation, and then the depression, and the anxiety, and you're spiraling down, and I find that you put people in a room with and I tend to put women in these online rooms, and they find community, they find purpose, they support each other, and that cycle starts to reverse back up. I think that many of these women need to re-engage with doctors. Some of them don't have the money. You know, they just don't have the money. They spend all their money. They need to re-engage with doctors, find the right doctors, find a doctor that connects to you. And I think that it needs to be addressed from a physical and mental health perspective, continuing forward. I think CBT is great, and I think also having at the same time, you've been lying in a bed for 3 months, you need PT. And you have to go forward with both those things. And I don't know whether the doctors need to brush up their language when they're talking to the patients, or that the patients have an own internal fear that maybe it's not real. And the only reason, because I had cancer, it was just amazing how when everybody supports you, walk into a room, you look green, you have bald, you have no hair, and you're in sweatpants, and people are like, you are beautiful. Thank you for coming today. Having this constant ray of sunshine jumped on you with having cancer, it is amazing. You show up at someone's house and they're just like thrilled. I was 300 miles near you, and I decided to come by and say I loved you. I mean, the amount of yumminess that you get in one injury versus the other. So, I do think it's very tricky, post-concussive syndrome, and I do think that you have to be approached from both perspectives.
So regarding this issue that psychological phenomena are not produced by the brain, which is how I interpreted what you're talking about, okay? After you got your chemotherapy, right, they didn't tell you that you had no cancer. They said, we can't detect cancer, and 5 years from now, we'll be much, much more confident that you don't have cancer.
They've actually even dropped that. They go, good checkup.
Yeah, right.
Good checkup. I keep going, where's the
But the
finish
point
line?
is, but my point is that not being able to detect it, no oncologist would say you didn't. That they were sure that you didn't have cancer, and that's basically the point I'm making here with respect to post-concussive syndrome. The fact that you cannot detect anything physiological with some of the methods that we use doesn't mean there's nothing physiological going on, and also the assumption that somehow mind and brain are different kinds of things is really a bit anachronistic, I think. So.
Thank you for making that point, because that is definitely not the way I think about things at all. And something that I spend time educating patients on is that even things like depression and anxiety are inherently neurologic phenomena. And so a lot of these symptoms are associated with those pieces as well. So we can't exactly disentangle all of that, and it is a manifestation of what's happening to somebody neurologically. So I would definitely never try to pull those two things apart.
I just had a comment. My name is Kuro Samami. I'm from Pittsburgh, the UPMC concussion program, and the whole we see this so much over there as far as the people that kind of spiral months and months later. We see injuries from 3-4 years ago that they come and they're still kind of struggling with issues, and that it's the power that they get when we kind of tell them, like you said, you're not crazy, you're not faking it. Like literally, it doesn't happen all the time, but you could see a ton of stuff just completely wash off their face. Their affect changes, and it is like a process. And we tell them this is not going to be a 1 day, 2 day, 1 month, 2 month thing. You've been living your life in this rut for months and years on end, and it's just going to take time to kind of disentangle this and kind of get you back into, getting back into the activities and stuff that you want. But when they do go down that wormhole, it's a battle to try to get them out. But with, I think, a lot of knowledge and education and kind of letting them know that they're not crazy does go a long, long way, honestly. So.
One other thing, when I had chemo, they told me to prepare for chemo brain. I'm like, what the heck is that? And I I remember waking up the first, and I can't remember if it was a day or whatever, and it was basically like having a concussion but no pain. So it was the fogginess, the mental health, and when you're watching the screensavers, and that feels like a show. You're watching the little animals on Apple TV. I can't look at those animals on Apple TV because literally I watch that for hours. But it didn't throw me because I'm like, wow, there's no pain here. I don't have a headache. I have no problem with this. Where other people that do chemo get completely thrown off on it. But it's interesting how chemo brain is accepted and part of the process, and in concussion, it's an invisible injury. So you go back and forth. And I think once imaging gets to a point, I spoke at Utah a month ago, and part of the speaker package was getting a functional MRI, which I didn't really want, and I asked if I could give it to somebody else, and they made me do it, and it was interesting. Yeah, they basically goaded me into doing it.
All right, we're just about out of time, but thank you so much to everyone who spoke this morning, and this workshop's been super productive, and thank you for everyone for engaging with us. So yeah, round of applause for everyone.